I thought of what could possibly be drawn from my experience that could be of use to you. And even though our experience from the Boston bombing doesn't quite fit in with chronic diabetic ulcers, I think some of the lessons we can learn from there are useful. And I think also what I have to say is probably of general interest to you, particularly the ones of you who are involved in management and planning of emergency rooms, disaster organizations, teams, you name it. The one on our team who led this effort after the bombing was Matt Carty, one of my colleagues in Boston. He did an excellent job. I just want to acknowledge that. And I also want to acknowledge the 5 other hospitals: the Beth Israel Deaconess Medical Center, the Boston Children's Hospital, the Boston Medical Center, the Mass General Hospital, and Tufts New England Medical Center, who participated in taking care of the victims. And it was a collaborative effort to also to try to amass reliable citywide data, although it's somewhat incomplete yet. And as you know, the Boston Athletic Association organizes the Boston Marathon, and it's an annual road race in Greater Boston. The finish line is downtown. It's held on Patriots' Day, which, as you know, is a civic holiday. An estimated 500,000 spectators are there annually along the race course, and most of them toward the end of the course where the bombing happened. And last year, there were approximately 27,000 registered runners and probably another 10 to 15,000 so-called bandits. And the event happened right in the middle of downtown, just before the finish line. And if you were to orient yourself, let's see if I can get our arrow here. You know, the race comes in from the west, starting in Hopkinton, and then runs through a number of cities such as Natick, Wellesley, Newton, Brookline, etc., gets into Boston, here on Boylston Street, right in the center of Back Bay, and the finish line is right next to the Boston Public Library. And the explosions happened right before there on the north side toward the Charles River, which is here over to your right. And the 2 IEDs detonated just shy of the finish line at 2:50 p.m. And the devices were concealed in backpacks that were deposited on the sidewalk. And there was a very high density of spectators right there. It was essentially a tightly packed mass of spectators. And if you look at the demographics, and they are limited, but most of these people were grown-ups and spectators. Only 3 runners got hurt. More policemen. There were 6 policemen who got hurt here. And there were numerous medically educated bystanders who could provide help and immediate care. So this happened a lot. It helped a lot. There was also a medical tent located within 150 yards of the explosions. Additionally, there was a timely, immediate activation of the citywide EMS disaster response, so that having this happen within 2 miles of 6 level 1 trauma centers is probably, in all the tragic, fortuitous in terms of location. And we were greatly protected after this happened. The FBI might have, they did ignore 2 warnings from Russia that one of these perpetrators would do it way before it happened, but they certainly came to look after us after it happened. This is the main entrance of our hospital, and we had a total curfew in Boston one day, which in itself was interesting. And there were a number of on-site responses, mainly putting on tourniquets, which saved the lives of many people, because there were just numerous people who got their legs more or less torn off, because the way these bombs were placed in pressure cookers and then packed with explosives and nails, they essentially aimed right out parallel to the curb and mainly hit people below the knee. So there were many who were bleeding profusely, but due to the circumstances I mentioned, they were very well taken care of almost immediately. The total number injured were 281, and 3 were declared on the scene, and all the others survived, which I think speaks to the effectiveness of the system. And once the whole thing was over, it was really comfortable to see that our trauma alert and ER system worked very well, in spite of the fact that many of the ERs were, or most of these ERs were hit by more than 50 accident victims within about half an hour. And most of them were treated at these 6 level 1 trauma centers. And most of them came by ambulance. There were a few who traveled by car to the emergency room and walked in. The distribution to the 6 medical centers, the one under the letter D is ours, the Brigham. And few of them were hypotensive. A few were, but not many. Most of them had a normal blood pressure, and nobody was comatose. And in the emergency room, the initial trauma measures were taken with the ABCs, and it turned out that these patients could actually be triaged and treated quite rapidly. And when it comes to the nature of the injuries, as I mentioned, the preponderance of the wounds were lower extremity injuries because of the way the devices were designed and placed. And there was a high fragmentation burden due to the combination of placing this in a pressure cooker container and then all the nails that they had put in there. And fortunately, these people did not have access to highly effective explosives, and they had limited training in how to use them, so therefore it did not turn out to be as bad as it could have been. And the thermal radius was quite limited. And there was a very high level of contamination of all wounds that we saw. And there was also human debris because of the fact that everybody was so tightly packed. Bone fragments and other debris from one person penetrated the next person. And if you look at the distribution of injuries, there were 76 to the face, 23 to the remaining head and neck, 9 to the chest, 9 to the abdomen, and 140 to the extremities and the pelvis. And here you see an example of embedded particles in the leg. And there were just a multitude of these injuries where parts of the lower extremities had simply been avulsed. You can see another example here. And of the initial operative management, 83% went directly to the OR, 11% went to the ICU and then to the OR, and 6% went to the floor and then to the OR. And this was within approximately the first 8 hours. And it's also interesting to note that almost 90% of these patients reached the emergency room within the first hour, so that the EMS alert system really worked quite well. And there was nothing special about how these were managed, just the usual triage, debridement, fixation, and coverage. And we were just using standard principles of operative management. This is one of our patients, a young woman who was hit in her lower leg, and the orthopods provided the stabilization. The vascular surgeons did the vascular reconstruction. 3 days later, we put the free rectus abdominal flap and a skin graft, and that turned out to be all the acute treatment she needed right then. And if you look at where the patients were discharged to, approximately half of them went to rehab and half of them went home after the initial period of treatment. And the average length of stay was 11 days. And once they had reached the hospital, nobody died. And we learned quite a few things from this. Timely tourniquet control saved the lives of many people. And to simply use the standard methods of triage and treatment and rapid operative management turned out to work quite well. And we tried to close these patients as soon as we could. And there were special circumstances that helped us. This was a civic holiday, and there were probably between 150 and 200 ORs in that area standing empty, and it was easy to recruit the surgeons necessary to staff them, which in retrospect was quite fortuitous. And as I mentioned before, there were 6 major academic level 1 trauma centers within 2 miles, well-educated population, a good on-site medical infrastructure, and a very effective EMS system. And also pretty much every place has full access to the breadth and depth of medical expertise. And if you look at the distribution of patients, it goes like this. And you have also the distribution of lower extremity injury patients. And these were the ones that were admitted. And if you look at the lower extremity injuries and which ones needed limb salvage operations and which ones required amputation, you can see that there are 34 and 15 respectively. And if you look at the institutional amputation rate, of course, these patients were not randomized, but there were many similarities among the patients. You can see that the amputation rate varied quite a lot, between approximately 22 and 50%. And you can see that in general, this trauma, the general injury severity scores are similar. So we have the hypothesis here that collaboration in the acute management decreases the amputation rate. And this is where we have the similarities with our area right here. And having trauma surgeons, orthopedic surgeons, vascular surgeons, and plastic surgeons work together seemed quite beneficial. For instance, at our place, 40 patients were treated acutely, and all 4 primary surgical teams were present in the emergency room upon patient arrival and took part in the triage. And there was an active circulation of members from all teams in the ORs during the acute management of all operative patients. There was a daily multidisciplinary, at least once, communication regarding definitive management plans and ongoing care, and a dynamic designation of lead service depending upon the stage and needs of the patient recovery. And if you look at the total number of procedures here, you can see orthopedic surgery and plastic surgery had the highest numbers, followed by trauma, vascular, and there was one patient with an eye injury who needed an operation. And also, if you look at the number of days in the hospital, here it's slightly different. Most patients were cared for on the plastic surgery or the trauma service. If you look at the discharge service, there, in the end, plastic surgery ended up with most of them. And I think here there are many similarities to what we are doing here, in that if you have an integrated care with combined triage, collective and collaborative operative management from the first contact, daily interdisciplinary communications, and a fluid primary ownership to the patient, compared to single triage, proprietary operative management, piecemeal solicitation of complementary teams, and guarded communication, and fixed primary ownership. It appears that the amputation rate is much higher. And this is what we came up with when we compared how the different institutions work. And of course, you have to build this collaboration and organize everything in a non-disaster situation. But I think you can recognize many of these factors in the way we care for diabetic wounds. And of course, the data is still preliminary, even 11 months later, and the long-term outcomes will be available later. As have been discussed a lot here, the value of limb salvage can be debated in certain situations. And of course, the patient's opinion, compensation, etc., may have influenced this, because the patients with amputations received quite a high level of financial compensation. That shouldn't play a part, but it probably did. So that we can conclude that the bombing at the 2013 Boston Marathon offers several opportunities for learning. And it appears that multi-specialty care results in fewer amputations. In this case, approximately half as many. Thank you.